In this clinical case, we explore tricuspid stenosis as a rare but important valvular heart disease. Primarily affects right heart inflow and systemic venous circulation. Tricuspid stenosis is defined as narrowing of the tricuspid valve, causing impaired diastolic flow from right atrium to right ventricle. Significant disease shows a mean diastolic gradient greater than or equal to 4 millimeters of mercury. Most cases occur in association with rheumatic mitral stenosis. Isolated tricuspid stenosis is rare and usually part of multivalvular rheumatic disease. Other causes include congenital abnormalities, while non-rheumatic causes remain uncommon. Rheumatic pathology remains the dominant etiology worldwide. Pathophysiologically, obstruction increases right atrial pressure, leading to systemic venous congestion. This results in hepatomegaly, ascites, and peripheral edema. Reduced right ventricular filling leads to low cardiac output at rest and inability to augment output during exercise. Tricuspid stenosis may also mask severity of mitral stenosis due to reduced flow. Patients commonly present with fatigue, peripheral edema, abdominal distension, and hepatomegaly. Dyspnea may be surprisingly mild despite significant congestion. On examination, jugular venous distension is prominent with giant waves in sinus rhythm. A slow Y descent may also be observed. A low-pitched diastolic murmur is heard along the left lower sternal border and increases with inspiration. An opening snap may occur shortly after pulmonic valve closure. Electrocardiography may show right atrial enlargement with tall P waves in lead II. Right ventricular hypertrophy is often absent despite right-sided failure. Chest radiography may reveal enlarged right atrium and superior vena cava. Pulmonary congestion is often less prominent compared to isolated mitral stenosis. Echocardiography demonstrates thickened tricuspid valve leaflets with diastolic doming. Severe disease is suggested by valve area less than or equal to 1 square centimeter or pressure half-time of 190 milliseconds or more. Doppler echocardiography estimates transvalvular gradients and evaluates associated tricuspid regurgitation. It also assesses right ventricular and left ventricular function, along with pulmonary pressures. Cardiac catheterization is rarely required, but may be used for complex hemodynamic assessment. It confirms pressure gradients when non-invasive imaging is inconclusive. Medical management includes salt restriction, diuretics, and bed rest to reduce systemic venous congestion. These measures help improve symptoms before definitive intervention. Surgical intervention is indicated in moderate to severe disease with mean gradient greater than 4 millimeters of mercury or valve orifice less than 1/5 to 2 square centimeters. Timing is critical for optimal outcomes. Tricuspid valve repair is preferred when feasible, while replacement is performed when repair is not possible. Mechanical valves carry higher thromboembolic risk compared to tissue valves. Percutaneous balloon commissurotomy is rarely performed and reserved for selected isolated cases without significant regurgitation. It remains a limited option in modern practice. Tricuspid stenosis is a rare rheumatic valve disease that primarily causes systemic venous congestion rather than pulmonary symptoms. Early recognition and appropriate surgical timing are essential to prevent advanced right heart failure.